All right. Well, the Office of the Vice President for Health Sciences is happy to welcome all of you here today, part of the Heal R21 Seminar Series on opiates. And this is all part of Stuart Clark's R21 project. And I will let him explain it further.
Thank you, Dr. Dietz. Yeah, so thank you to the Office of Vice President for Health Sciences for helping us organize this. Dr. Dietz, you did fail to say that this is build up to the director of NIDA, who's coming next week. And you should have already, because you have to register for that, right, Karen?
We want you to register.
You
Yes.
want to register. Okay. And so that's next week, April 1st. And then in a week or so after that, we'll have Dr. Nielsen coming in to talk about her experiences. And so this seminar series spawned out of a HEAL grant. So if you don't know what HEAL initiative is, it's helping end addiction long term. It's centered on finding alternates for opioids and looking for ways to help opioid addicts or people with substance use disorder. And so we have a grant, R21, to do a preclinical trial for a compound that we have developed in collaboration with Research Triangle Institute in North Carolina. We've shown that it curbs drug seeking, specifically cocaine seeking, in rats. Haven't gone to humans yet. But we have money to do the preclinical trial in opioid related behaviors. And so as part of that, the HEAL initiative requires me to have people involved in the project that have lived experiences, and that can be physicians, patients, the whole gambit of people who have been impacted by the opioid crisis. And so today we have Dr. Joshua Lynch, who has been part of our UB community since 2008, I believe. He's currently the physician of emergency medicine, medical director of Mercy Flight of Western New York, which I found super interesting, and co-chair of the clinical services of the Institute on Addictions. He has earned numerous awards, most recent being the New York Society of Addiction Medicine Clinical Innovation Award. Today, he will be sharing his story of bridging the Harm Reduction Gap Matters program, which I believe has been at least a 10-year passion for him. So, Dr. Lynch.
Thank you very much, and thank you for having me today. So this talk's going to kind of take a few different directions. We're going to talk a little bit about some emerging drug threats, a bit about harm reduction, and walk through the Matters program in a little bit of detail. And I want you to keep in mind while we're going through this that the resources that I'm going to be discussing and sharing today are available right now. So this is equally as relevant to ourselves as faculty, but also as members of the community, friends, family members. So if you are looking at this from a professional lens, these are tools that are available to you today, and I'll share some information on how to expand on that. But also, if you're looking at this through the lens of a concerned family member or friend or coworker, there are also resources that will be relevant in this talk. So while I don't have any commercial disclosures, I just wanted to share that we are fortunate enough to receive funding through the New York State Department of Health, through New York State OASIS, and Allegheny County Department of Human Services in Pennsylvania. And also some of the work that I do is supported through a research grant through New York State OASIS. Just to level set, why do we have such problems accessing care for patients with opiate use disorder, but you can expand on that to substance use disorder in general, mental health, hepatitis, HIV? Why is that so challenging when other disease processes, we really trip over ourselves to come up with slick ways to link people to treatments, such as those with cardiac disease or stroke diagnoses? So it's kind of a pathway. Substance use disorder in general is something that many people struggle to admit or to talk about or to reach out about for support. And in many cases, it's not easy, which leads people to feeling isolated and alone, which further exacerbates people not reaching out for help. And what's next? Accessing treatment often ends up in people waiting in a line or waiting in a virtual line, waiting for an appointment. And even in the course of regular medical care, substance use disorders in general may be overlooked or not necessarily prioritized in the course of a discussion, even though it may come up in a subtle way. I think I've certainly seen that in the emergency department, and I would suspect that you might have seen that in your clinical practice as well. I want to share an opportunity that we were given in Buffalo to be highlighted on CNN. And this piece is being aired this Sunday night at 8 o'clock. And Buffalo doesn't hit CNN that often. So I thought I would just ask for a minute and 59 seconds of your time to take a look at this trailer. This features a few folks from Buffalo, mainly Dr. Paul Updike, who is an addiction physician at the Catholic Health System, and Dr. Lauren Davidson, who is a neonatologist with Catholic Health as well. This special will feature Buffalo and Camden, New Jersey. So I hope you enjoy the next just under 2 minutes.
We found you overdosed in a parking lot at the gas station, okay? You weren't breathing?
Addiction is very painful. It hurts.
It changed my whole chemistry and my way of thinking.
I wanted to be clean so bad, but it's just too hard.
I thought, this is my poor daughter. What happened to you? What happened to you?
Where are you?
Where are you? But I knew she was always in there.
Were you nervous to tell me your story?
Yeah, for sure.
Why?
Because what kind of piece of shit uses when they're pregnant? It was terrifying.
People paint drug dealers as, I don't know, you call them a boogeyman, you call, you know, you are the bad guy. Why'd you want to talk to me? She relapsed.
She's in severe withdrawal. It's actually more dangerous to stop using if you're already pregnant. It doesn't go away.
I'm not saying that no patient could be weaned off and remain stable. I'm saying very few. We have a male in his 30s that's unresponsive and not breathing.
Oh my God. I'm not scared. It can cause the baby to die. It is still there.
I never really understood what a drug addict was. Now, after experiencing it, I see it a lot differently.
So Kate Bolden and Anderson Cooper are going to be telling this story on Sunday night. And if you are free around 8 o'clock, I would recommend that you take a look. I think this is a nice way to highlight the work that is being done in Buffalo. Granted, just a small segment of the work that's being done here. So yeah, I hope you enjoy. So what does all this mean, really? I think that for many years, for lack of better resources or even maybe understanding, the primary way of treating or referring people to treatment with substance use disorder, at least in the emergency department, often ended with this type of interaction. Patients being handed a list of treatment options that had phone numbers that maybe weren't active and perhaps did not have appointment availability in the near future. And we really set out to change that. Just one other kind of point of discussion of why people don't have access to treatment. And we had talked a little bit about it's not really an easy problem to admit or reach out to people that you know and love about this problem. There certainly has been limited access to high quality treatment and access to medications themselves. And then, of course, the financial and transportation aspect of physically getting to a treatment appointment and also being able to pay for that if you don't have insurance or having access to medication. Want to give a shout out to our fantastic team that is located in Buffalo and also across New York State with our regional outreach coordinator program. We have a great group of physicians that provide expertise and advice in different aspects of the program, and our outreach team, which is spread across New York State, in the central New York area, greater capital area, and downstate in Long Island and New York City. They do a tremendous amount of work. And our newest outreach coordinator in Pittsburgh, Matthew. So if you kind of break up the Matters program into like obstacle mitigation, and linkage to treatment was really the first step. We realized that it was more than just linking people to treatment. It was providing access to medication, financially, transportation assistance, and then more recently, the adoption of harm reduction resources, which we'll get into in a few minutes, and then telemedicine, which we'll also kind of highlight in detail. If you break it down to even easier than that, there's really three tenets: rapid evaluation, access to medication, and referral to treatment. Sounds a lot easier than it is, for sure. So if you think of the Matters resources that we're going to walk through as being kind of in the middle space between where people with substance use disorder may experience problems and linking those people to high quality treatment. And it's not just the hospital. People have issues with opiate use disorder and crisis and overdose and withdrawal and other issues outside of the hospital as well. And expanding resources and linkage support to places like the scene of a 911 call, whether that's EMS, police, or fire related, community outreach organizations, homeless outreach teams, other places that are not just the hospital. And what we've seen over the past several years is that actually people with opiate use disorder prefer not to come to the hospital if they can avoid it at all. So transitioning these resources out further into the community has been something that has been really important. So you may have heard of some of the efforts that have been conducted at Yale. Yale did some of the first formal studies under the direction of an emergency physician, Dr. Gail D'Onofrio, who really started to demonstrate that, wow, starting people on buprenorphine or Suboxone in the emergency department and providing them some linkage to treatment, that works better than not doing that, which, in turn really kind of boils down to a pretty simple concept. Again, much easier said than done. Now, the majority of the country is not Yale, and Buffalo is a perfect example. We have a sophisticated medical system, but we don't have a centralized university medical center per se with a network of university outpatient treatment options. So moving people around a very coordinated system, especially with opiate use disorder, may be complicated to a certain degree. But you look at a place like the greater Buffalo area, you have many hospital systems, many layers of outpatient treatment organizations. Having a patient navigate that system with a disease process like opiate use disorder is incredibly difficult. It's difficult for us to even move people around, and we know the system. So one other comparison would be the California Bridge program, which is a program that focuses on emergency department assessment and linkage through a fairly expensive model of substance use navigators that are employed and are physically present in many hospitals across California. So Matters is a bit different, and as we walk through the next few slides, I'd like you to just kind of keep that in the back of your mind. So I want you to meet Tom, who was the first Matters patient, actually. Tom, and this is Tom at the medical school helping out to spread the word of our statewide expansion a few years ago. And Tom had come into the emergency department actually with someone else who was the patient. Tom was actually not the patient. And in the course of discussion, we were helping the person that he was with, and it came up in discussion that Tom struggled with opiate use disorder, and we were able to link him to treatment in a pretty rudimentary way with some of the outpatient treatment organizations that we had been talking with. And he really didn't kind of understand the unique opportunity that we were giving until we circled back a few years later and caught up with Tom and realized that he had a job, he was doing very well, he was in a relationship. And this is just one small example of success when you can just help someone out and help them navigate the system. We didn't provide any cutting edge medical treatment for him. We just helped him navigate. And that was really kind of the premise of the focus of the Matters program, was to help navigate the system, but also break down barriers and overcome obstacles. Just an acknowledgement to the funders of the Matters program in general, particularly the John R. O'Shea Foundation and also the Blue Cross Blue Fund, which were our first two supporters when we were not really that organized, had a vision, and needed some support to execute that vision, which I think we've done pretty well. But if it wasn't for those two groups, who knows where we would be. So looking at the assessment process and linking people to treatment, we really set out with three pretty specific goals: connecting individuals to treatment where they choose. So if they're sitting in a particular institution, having them have more options than just that institution's outpatient treatment network, which sometimes doesn't work for people. Maybe they've gone there before and they don't like it, or they have a friend that had success with a different organization to follow up with. So we put patients in the driver's seat, let them choose. And of course, minimizing the window from the time that we're encountering them, wherever that might be. It might be at the scene of a 911 call, at their home, or at a gas station, or in one of the emergency departments. And minimizing that time from when we can get them to where they want to be in front of the resource that they need. And then for those that aren't necessarily in a medical setting, or don't want to go or can't go to a brick and mortar treatment appointment, layering on telemedicine for evaluation, access to medication, and linkage to treatment. So it's we don't have to read all this, but the take-home message of our core values is putting the patient first, letting them choose, and letting them choose from a high-quality network of treatment organizations that have been vetted to prove that they understand the complexities of care for patients with opiate use disorder. And basically what I mean is treatment organizations that are willing to accept patients with whatever baggage they come with, whether that's no health insurance, polysubstance use, co-occurring mental health disorders, whatever. Having people that are referring someone to treatment, asking them to navigate insurance complexities, comorbidity complexities at 3 o'clock in the morning during a busy emergency department shift is not realistic. And I think that's why other efforts of this sort have failed in the past. We come to the person making the referral with a set of vetted treatment organizations already, and it takes the work off that healthcare professional or police officer or whoever is helping to facilitate that linkage. So this program started in Buffalo in kind of, I guess, formally 2017, and have really grown across New York State to a network of referral sites, receiving sites or treatment organizations, peer support agencies, and I'll mention that a little bit more later. And then also private pharmacies. We'll also get into that in a few minutes. But I want you to think about the geographic span and complexity of expanding across New York State, which is a pretty geographically diverse state with a wide range of resources depending on where you are physically. What we've been able to do is identify over 300 different referral sites, all from we talked about the categories of what the referral sites are, and have had 250 plus treatment organization locations. So some organizations may have multiple locations, but that many places for patients to pick from that have already been vetted, that have already agreed to figure out a way to take care of patients without health insurance or comorbidities or other things. The pharmacy locations are a mix of independent pharmacies, but also commercial chains which accept our medication vouchers, which I'll explain later. But the really important thing is that for those that might be thinking, well, there's just not enough treatment out there, just in our network alone, and we haven't partnered with everyone. We've partnered with about 90 hospitals, so that's about a third of the hospitals in New York State, maybe a little bit more. Just this program has been able to identify over 2,500 appointment slots per week, giving patients really a choice that they haven't been used to experiencing in the past. One other section of linkage is law enforcement and courts, and also New York State Department of Corrections, and a variety of county jails across New York State. So you might be aware, but at a period of incarceration, following reentry after the period of incarceration, individuals are much more likely to suffer a fatal overdose for a variety of reasons. So linking people to treatment in that transition time between being incarcerated and getting out and kind of re-entering into regular life and society is a very high risk transition period. So on the Matters Network .org website, I put it in the chat if you're a multitasker or just have a short attention span and need to be doing two things at once, like me. Feel free to browse the website. But this is one way to begin the process of linkage. And our mobile app is one other way. And this is just a quick clip of what the mobile app looks like.
The all-new Matters mobile app. Now it's easier than ever to link to treatment, order supplies, submit draft referrals, and access resources. Download today on the Apple Store and Google Play Store.
I told you that we have a really talented team that works right at the Gateway building in Buffalo, and I think this is just one small example of some of our great work. Just one other way to take a look at this. So on the mobile app, I'll share a QR code, or you can just search Matters Network in the Google Play Store or Apple Store. This offers resources for individuals. It offers professional resources and linkage resources for healthcare professionals or other folks that are in the position to refer, whether that's a drug court or a jail or variety of other people. You can also request a telemedicine visit in New York and in the greater Pittsburgh area as of yesterday. So the app is of course free and provides a lot of resources. I would recommend you taking a look. Just to get into the linkage portion of this a little bit more. So we knew that we had to have something accessible 24 hours a day, and we also knew that we couldn't ask people to make phone calls, or if we did, probably wouldn't be successful. Waiting on hold during the course of a busy shift or a busy clinical day is really not in the cards for many people. So this is accessible 24 hours a day. It's kind of exactly what you would expect as far as the intake process. It's designed to take 2 minutes. We collect just some, basic demographic information, a little.
Josh, you're frozen.
A piece of this, and when I refer patients from the emergency department, kind of the moment that turns the tide on the interaction is offering patients a map of treatment organizations that have already agreed to cut through all the barriers and take people just like that individual that's being referred. This map isn't fully populated, but imagine sitting with someone who you're helping get linked to treatment, and you see a map based on their address. You click one of the markers. It shows you what services are offered there. So everyone offers medication for addiction treatment, but there are also other markers like treatment for hepatitis C, HIV, mental health, other substance use disorders. If they provide, if that treatment organization identifies that they are a syringe exchange program or offer injectable buprenorphine, if they offer methadone, if they identify as a low barrier, treatment organization, or many other things. So we know that it's tough for this patient population to get to an appointment, and we want to make sure that they're going to an appointment that meets their need, or going to a place that can meet their needs, rather than trying to expect them to go to multiple places. So they're able to select their appointment date, and then all this happens really on the back end. Information is sent over to the treatment organization that they've selected. Limited information is sent to the peer organization if they wish. Confirmation comes back to the patient via text message, email, and a printout, depending on where they're being referred from. And then they also get entered into our post-referral engagement or follow-up process, which is super important. So we know that patients may fall through the cracks. This happens with any disease process, but we know that patients with substance use disorder are even more likely to fall through the cracks, be lost to follow-up, and particularly may be exposed to making bad decisions or dangerous decisions even after their linkage. So our support services team reaches out immediately after referral, and then again at 30, 60, 90 days, anticipating patients having more problems. So those calls can help with identify transportation barriers that could be preventing them from going to their appointment, or whatever other problem that they may have. We can relink the patient right away on the phone without hanging up or going through any complicated process if something happened in their life that they need to be given another opportunity. And that's part of the process and exactly why we built out this follow-up set of services. I alluded to the medication voucher earlier. We obviously have worked really hard to try to link patients to treatment. However, if patients get a prescription for medication, whether that's buprenorphine or Suboxone, or something else, and they go to the pharmacy to get the medication, and it turns out that their Medicaid isn't active or whatever, and they're asked to pay $100 or $150. Usually, if they can't do that, which is in many cases they can't, the process is completely derailed. So we developed a voucher program in partnership with CVS, Wegmans, Walgreens, and Duane Reade down in the city, to just no questions asked, just pay for 2 weeks of their medication, and that's any buprenorphine naloxone combination, any formulation or even brand name of that medication with the purpose of eliminating that barrier for patients. So it's not only at these chain pharmacies, there are many independent pharmacies which are fantastic to work with across New York State and in Pittsburgh that also accept the voucher as payment. You still need a prescription, but the voucher covers the payment. One other piece of support services, which shouldn't be a surprise to anyone, is transportation assistance. Everyone that's referred is given instructions for transportation assistance. All this is immediate issuance. There's not you don't have to apply, you don't have to wait. You're not getting denied. It's just offering resources that we know people need. And the transportation voucher program is currently offered with Uber. There are some other regional transportation or regional organizations that provide transportation across New York State, particularly in the rural areas, that we are working on developing relationships with so we can offer even more transportation support. Telemedicine has really evolved over the last 5 years. This is something that has been involved in different aspects of medicine for a very long time, but has really, I guess, kind of been simmering on the back burner for many years. And COVID really brought that into the forefront of not only providing care for patients with substance use disorder, but a variety of other disease processes too. If you didn't know, UBMD Emergency Medicine has actually been providing telemedicine services for many, many years, going all the way back to the early 90s with the New York State Department of Corrections, and we've done a variety of other things, a variety of other projects with telemedicine in New York State. However, in the spring of 2020, we expanded our telemedicine to offer virtual emergency services to Kaleida Health and ECMC. What we saw very quickly was that the majority of people utilizing the virtual ER were patients with substance use disorder anyway. And that is not exactly why we built the virtual emergency departments, but we quickly adapted to offer a quick assessment, access to medication for addiction treatment, and linkage to care through the Matters program, right on the emergency telemedicine assessment process. So someone from their own home could log in, request a telemedicine visit. They are assessed quickly. They have access to medication, and they get linked to treatment. And in some cases, they could be linked to virtual treatment or ongoing tele-addiction care and never have to leave. That may be less of an issue in Buffalo, but it's certainly a problem up in the North Country or in the rural pieces of the Southern Tier where there are not many treatment organizations to pick from. And we've continued to grow this telemedicine program through UBMD Emergency Medicine in partnership for a variety of other things. So as I mentioned, telemedicine really kind of had been on the back burner for many years, and we were able to adapt quickly in spring and summer of 2020 to make sure that we not only would continue to offer virtual emergency department care, but adapt to layer on the Matters suite of resources for patients with opiate use disorder. And turns out, if any of you had taken advantage of telemedicine, care either during COVID or beyond, we like it. It's handy, and if you can have a follow-up on telemedicine and it's appropriate for whatever you're being seen for, rather than drive to an appointment, it's handy. And in the angle of substance use disorder, those that are afraid or aren't getting treatment because of the perception of stigma, telemedicine is a great way to minimize stigma and minimize anxiety of going to an appointment. Over the last couple of years, we have layered on harm reduction strategies to the Matters suite of resources in addition to linkage services, vouchers, et cetera. We had been interacting with a greater proportion of patients that weren't necessarily ready to go kind of all the way to getting treatment, getting on medication, and they were asking us for ways to just use safer. And that's really kind of fits on the continuum of care in the harm reduction area. And we started off by offering naloxone trainings, and then added on the availability of fentanyl and xylazine test strips. One other piece of the harm reduction services are harm reduction vending machines, which I just wanted to highlight a very short clip that the University at Buffalo Jacobs School of Medicine put together for us. They did a fantastic job. This is the short version. It's about 1 minute. Just highlighting our harm reduction vending machine program, and I will explain that a little bit more. This is for patients that don't necessarily can't or won't wait for harm reduction supplies to show up by mail. So again, the huge thanks to the medical school for putting this video together. In mid-2023, we launched a statewide harm reduction vending machine program. This was really important because we know that patients are sometimes reluctant to walk into a building and ask for drug testing supplies. Someone can just walk up to the machine 24 hours a day. They type in a code that's listed on the outside of the machine. They enter their year of birth and their zip code, and they can select items out of the machine that they need. So what we have stocked currently is naloxone, fentanyl test strips, and xylazine test strips. If you're looking for a location of one of the vending machines, the easiest way is to go to the mattersnetwork.org website, click on harm reduction, and there's a vending machine page that has addresses on a Google map of where our vending machines are located. So this is the map of the vending machines. We have just over 20 that are on the ground and operational right now. There are some community-based machines that are not part of the Matters network. The interesting thing about these machines is that they're all outdoors and they're all accessible 24 hours a day. They're temperature controlled to be able to access supplies out of them. We are working with the Department of Family Medicine and the Primary Care Research Institute on an evaluation process for these machines, and are in the early stages of developing a couple manuscripts to highlight the development of the network, but also the functionality and the efficiency of a statewide network of vending machines. We do have funding for additional machines that is available now for the next few months. If you know of or are interested in learning more about that, please reach out at the end. We do have a couple machines in Buffalo, one at the Goodwill on William near Bailey, one at Alba de Vita on the west side, one at the Kenmore Village Fire Department, up just kind of by the Kenmore, just north of North Buffalo, and a few more. The test strip distribution program was in partnership with New York State OASIS in support of their harm reduction delivered campaign. And we got in pretty deep with test strip distribution and have now surpassed the 21 million test strip mark that have all been distributed out of Buffalo. So we're proud of this. This is the test strips the packaging has been rebranded to offer educational information and also a QR code to assist with linkage to treatment for patients that might be interested. We have a manuscript on test strip distribution in peer review now and are working on version 2 with our research colleagues in the Department of Emergency Medicine. On another harm reduction note, just last week, our mail-based syringe service or syringe exchange program, it's syringe services. We're not taking syringes by mail back for exchange, but this is a mail-based program in support by the New York State Department of Health AIDS Institute. And if you're interested in learning more about this in your practice, you can scan the QR code or just go to our website and take a look. If there are individuals that you are working with that might be a candidate for this type of service, we are accepting applications for new participants. We'll wrap up here soon, but I wanted to just give a little bit of information on a couple drugs that you might be less familiar with. Xylazine is probably the most familiar of the less familiar ones. This is a veterinary medication, also known as Tranq. It actually was developed with the original intent of being an antihypertensive. This was developed by Bayer. The trial stopped because of profound hypotension and CNS depression, and Bayer pivoted to having this be a large animal veterinary medication, which is actually approved, which makes it actually more available. It is a sedative and tranquilizer and causes significant hypotension and decreased level of consciousness. Where we're seeing xylazine come in as an adulterant to the fentanyl supply, this can prolong the degree of euphoria that people may experience by having it be mixed with fentanyl. It is important to know that this is not an opioid, so if someone has a mixed overdose or a mixed ingestion, naloxone should still be given, but it will not necessarily reverse the effects of the xylazine. These you might be a little less familiar with, so you'll notice QR codes on the top corner here. This would take you to the education page for each one of these respective drugs. Our folks have put together some really great educational documents, referenced educational documents on these drugs if you're interested to learn more. This is tianeptine, or also known as gas station heroin, which is a huge problem in parts of the country. This is an antidepressant that has opioid receptor agonism activity, can cause euphoria, and it's sold in gas stations, believe it or not, for now, and among other places. Can also cause opiate withdrawal. And again, for this, naloxone should be given, especially the fact that it does have agonism effects on the opiate receptors. One other drug is called ibogaine. There's another educational document linked here. This is a Schedule 1. It provides hallucinogenic and properties. People typically chew on the roots of this or ingest it in powder form. There was some discussions publicly about could this be a low-cost alternative to buprenorphine because it has some agonism of the opiate receptors. Those meaningful studies really have yet to be published on this, but I thought it was relevant that we at least touched on it so you were aware that this is out there. And if you're interested in reading more about it, please check out our website. Then just a couple other emerging or just other kind of related threats, which one is kratom, which is pretty available. That's a partial opiate receptor agonist. Medetomidine, which is an alpha-2 agonist, that you might be more familiar with dexmedetomidine or Precedex, which is used in the medical setting, and also nitazines, which are extremely potent synthetic opioids. And this is actually a concern as the crackdown on fentanyl importation into the United States continues, that other synthetic opioids will kind of take the place of fentanyl, and nitazines would be one of those drugs that we are quite concerned about given their potency. I wanted to share just on our website, we have a fair amount of addiction-related, emergency medicine-related publications that are really within the last few years. I just wanted to highlight 3 of them. One is a white paper that we put together with a variety of other institutions across the country for the Academic Academy of Emergency Medicine, American Academy of Emergency Medicine. This is really, I think, pretty easy to navigate. It's put together as a question and answer document in regards to common questions that people may have when utilizing medication for addiction treatment in the emergency department. And then 2 others, these were published this year. Actually, the comparison of 30-day retention and treatment among patients referred from telemedicine versus the emergency department. This was just published last year. And this is actually really interesting in the sense of this demonstrates patients that started off after an emergency telemedicine assessment, followed up both at their initial visit and their 30-day visit at much higher rates, statistically significantly higher rates than those that were referred from the emergency department. And this is reassuring on a few different levels. One, I think it reiterates the fact that telemedicine is a great way to provide care for a variety of disease processes, but particularly opiate use disorder. And patients typically encounter less stigma and see a more efficient way to navigate the healthcare system with OUD, starting off on telemedicine. The implementation paper was published a few years ago, and this is really just kind of describing the setup of the Matters program if you're interested. In the QR code here will take you to our research page off our education page. So just a couple frequently asked questions, and then we'll wrap up here. Patients can be referred more than once. We know that this is not necessarily a disease process that is cured with the first interaction, and often takes many times, and many interactions might look different. The Matters referral does not automatically issue a prescription for buprenorphine. This needs to come after a telemedicine evaluation or in some other environment, whether it's a primary care office or hospital, for access to medication. If someone needs medication prior to their appointment, we typically would direct them to telemedicine service for evaluation to determine if a bridge prescription would be appropriate or not. Typically, the appointments are available to individuals. I mean, usually the next day. There is, particularly in Western New York, there is a wide range of participating treatment organizations that have been fairly generous with appointment availability. We don't offer a specific time. This allows for flexibility and life to happen for both patients, and flexibility on the treatment organizations and as well. We did talk about the outreach team and the support services folks providing a variety of callbacks and post-referral engagements. I did just want to share about Pennsylvania. We are going live with telemedicine services in Pennsylvania. That's happened this week, and we'll be facilitating referrals later this spring in the Allegheny County region, and have plans to start work in New Jersey, particularly in the Camden County area, soon as well. And throughout the course of 2025, our intention is to add additional disease processes. Think along the lines of having this process be an available linkage option for patients with mental health diseases, alcohol use disorder, and others. So what can you do now? I'd invite you to our website to explore not only the website, but the app, sign up to either make or receive referrals, host a vending machine, or spread the word, and just reach out to collaborate. at the end of the day, I would hope if you're a clinician that you would like to learn more about buprenorphine if you don't know, and if you're not prescribing that, or if you're in the situation that you could, but you're not yet, there's a quick kind of reference guide about buprenorphine at this QR code, and it's not that intimidating. And I thank you for your time. And if there are questions, you can either enter them on the chat or just ask. So thank you very much.
Thanks, Josh. Any questions?
Dr. Dietz, was there anything in the chat?
There's nothing in the chat other than Josh put a link to the Matters website.
Okay. Dr. Lynch, I have one question. Oh, go ahead, Ken.
No, I was just turning my camera on. That's all.
Okay, sorry. Dr. Lynch, so I have opioids in my lab now, and I only have one Narcan kit. Where do
I
we
can
go?
help you. We can help you with that.
Okay. Do you want to
Yeah,
describe that
well,
for other people? Because I know there's other researchers that have opioids in their labs.
yeah,
And
we would be more than happy to provide Narcan to anyone that needs it for any reason. You don't even have to tell us the reason. You can go on our website and request, or I will just include our emails in the chat as well. And feel free to just send a confidential email and we will get that taken care of. As I mentioned, our offices are right at Goodell and Ellicott at the UB Gateway building. So if you're around there, we'd be happy to meet up there, or our outreach team would be happy to come out to your office or lab and drop it off.
thank you. So I have another question. So you mentioned that you want to reach out to and include other mental health disorders, specifically other substance use disorders. Is the Matters Network going to be able to work with PTSD and other anxiety, stress related disorders, or how far reaching is your vision or your capabilities in that?
So I have a pretty wide vision for where this program will go in the future. And our plan is to, as we navigate through obstacles and break down barriers, to include the disease processes that you mentioned, and others. Building the foundation of this program based on opiate use disorder was very challenging and took a long time. And we feel obligated to expand this linkage and resources for people that are struggling with other disease processes, like the ones you mentioned and beyond.
Thank you.
Actually, I have a quick question. So is there a linkage with the 988 crisis hotline?
So not formally. There are a variety of organizations across New York State that are the call taker, like the regional call takers for 988. And we have worked with several of them. Having closer partnership with those organizations is another goal of ours for this year. Think along the lines of someone calls 988, substance use disorder comes up or opiate use disorder comes up. We would like to get to a point where that 988 operator could run the patient through a Matters referral, or at least give them information so that they can help navigate the system easier.
There's no other questions. I'd like to thank Dr. Lynch. It's been great, and this is a great addition, and ramp up to Dr. Volkov, who's coming next week. Please register. Dr. Dietz would appreciate pre-registrations, right? But you're still more than welcome to join if you don't, right, Karen?
Yes, technically, yes.
Technically, yes.
It's just helpful to know how much interest there is, and then UB can report, the number of participants that we had for future planning. But the link is out there. I think you can access it through the calendar, the UB calendar, as well as I know Jill just sent out a reminder email that it's coming up. So if you're part of the listserv, you probably just got an email about half an hour ago from Jill that's advertising the talk, that you can click on the link to register.
Okay. And a question did come up in chat. Dr. Daria, did you want to unmute and ask your question?
Hi, sorry, I was just eating my lunch.
Oh,
But,
sorry.
My question was, is Hep C Care part of your program?
So right now, we don't necessarily have the ability to link someone with just hepatitis C to treatment. When you go through the referral process, though, the treatment organization's capabilities are listed on their profile on the map. So you'll be able to see if that organization offers treatment for hepatitis C, among many other things. So I guess not exclusively for hepatitis C, but as another disease process, you'll be able to pick a treatment organization that offers treatment for it.
Was that sufficient, Dr. Daria? He's eating his lunch. Okay.
There are also several hospitals that participate with the FOCUS program, which helps facilitate linkage for patients diagnosed, increased screening and facilitation of linkage to treatment for hepatitis C. I do know that program is particularly active at Kaleida and maybe at other places in Western New York.
All right, great. Any last minute questions? Otherwise, thank you, Dr. Lynch.
Thank you. Have a
All
great
right.
rest of the day, everyone.